MedTerm presents a lecture on tuberculosis. Tuberculosis is rampant in Pakistan, and you all will come across many patients with active TB or tuberculous complications in the ward rotations. Hence, it is extremely important for every medical student to have a firm grip of this topic and to be well aware of the management as well as the preventive aspects of this disease. Because of its widespread and common encounter in the hospital settings, it is a very important examination topic for us. To start the lecture, we will first discuss the objectives of this lecture on tuberculosis. Objectives. Define what bacteria can cause tuberculosis. Describe how someone can get. Describe how TB is diagnosed. Describe the treatment process for someone diagnosed with TB. Describe how employees can monitor their own TB status. What is TB? TB is a disease caused by infection with a bacteria called the Mycobacterium tuberculosis. Tuberculosis. In 1882, Robert Koch said that 1/7 of all human beings die of tuberculosis, and if one considers only the productive middle age groups, tuberculosis carries away 1/3 and often more of these. Tuberculosis is a disease caused by tiny bacteria that enter your lungs when you breathe them in. TB germs are most commonly found in the lungs, but sometimes they can move to other parts of the body. When you have TB disease of the lungs, you can spread it to other people. Mycobacterium tuberculosis is the causative agent for tuberculosis. This picture shows its histology. Details of the histological features will be discussed in a separate pathology lecture. Mycobacterium tuberculosis is an obligate aerobe. It has a droplet spread, has high virulence. Reach alveoli, enter and kill macrophages, then cytokines are produced and a caseating granuloma is formed. Susceptibility is either genetic or acquired, for example, malnutrition, HIV, age, steroids, TNF blockade. Now we will talk about the spreas. It can be hematogenous, lymphatic or endobronchial spread. 5 to 10% develop active infection over lifespan. 50% of these within the first 3 years of infection develop the primary disease. Most common risk factor for death in low prevalence countries is a failure of diagnosis. TB is a global problem. WHO declared TB a global emergency in 1993, declaring that 1/3 world population is infected. The reasons being: major problem with affordable therapy in some countries. Issue of generic drug manufacture. American attack on pharmaceutical factory in Somalia removed the only source of available medication. There are 8 million new cases every year and 1.3 billion are infected. 9 million have active disease and 2 million die annually. The fatality rate is 23% and the fatality rate for HIV-positive TB is more than 50%. Estimated TB incidence rates in 2010. Estimated HIV patients who got TB. TB has an airborne transmission. How can you catch TB? TB is spread through tiny drops sprayed into the air. When an infected person coughs, sneezes, or speaks, or another person breathes the air into their lungs containing the TB bacteria. How can you catch TB? TB is not visible and can only be seen under a microscope. TB droplets are more easily spread in areas with poor air circulation. TB infection and disease. The lungs are the most common place for TB. This is known as pulmonary TB. TB of the voice box is the second most common and is usually called laryngeal TB. TB invades and infects the lung. Effective immune response. Infection limited to small area of lung. Immune response insufficient. TB is a multi-system infection. TB in the US. TB rates decreased in the US and Western Europe even before TB drugs were available because of better nutrition, less crowded housing, public health efforts, earlier diagnosis, limit transmission to close contacts, TB sanatoria, surgery. TB in the US, single drugs use produced resistance, so multiple drug therapy was introduced. In 1990s, TB re-emerged as a threat because of TB-HIV co-infection. Drug-resistant TB. Globalization allows TB to travel. All this increased support for TB prevention and control. Funding for public health efforts, case management, contact investigation, directly observed therapy. Better diagnostic and patient management tools. The new drugs and/or drug combinations were introduced to allow shorter courses of treatment. Shorter, simpler, less expensive treatment regimens. Vaccine beyond BCG. Support for global TB prevention and control activities. Rapid diagnostic tests for limited resource settings. Better coordination of TB and HIV prevention treatment programs. Reliable access to TB drugs. Now, we will discuss the natural history of TB infection. After the exposure to TB, no infection develops in 70 to 90%, and infection develops in 10 to 30%. Latent TB develops in 90%, and active TB develops in 10%. Untreated patients die within 2 years of active TB infection. Latent TB versus active TB. Latent TB. The goal is to prevent future active disease. TB infection. In latent disease, there is no active disease. The patient is sick and infectious. In active TB, the goal is to treat to cure and prevent transmission. TB infection which has progressed to TB disease. The patient is usually sick and usually infectious if pulmonary. Usually not infectious if not pulmonary. TB infection and disease. There are two categories of TB. Latent and active TB infection of the lungs can fall into two categories of disease. Latent TB or active TB. Latent TB means a person is infected by TB bacteria, but cannot infect others, and is not coughing or appearing sick. Latent TB means the body's immune system has contained the infection. Persons with latent TB are identified by a positive skin test, PPD. Persons who are not infected with Mycobacterium tuberculosis have a negative skin test, PPD. When a person with a previously negative PPD converts to a positive PPD, the conversion indicates recent infection with M. tuberculosis. Categories of TB active. Active pulmonary TB means a person infected with the TB bacteria is sick and can infect others unless they are taking medicine prescribed by their physician to treat TB. Persons with active TB disease usually have some of the following symptoms. Cough 3 weeks or more. The patient usually feels weak, there is fever, loss of weight, night sweats, cough up blood, chest pain when coughing. Primary tuberculosis. Primary complex plus lesion plus draining gland, usually asymptomatic skin test conversion. Post-primary pulmonary tuberculosis. Local spread leads to the pneumonia. Hematogenous spread leads to miliary TB. Spread to bones and joints. Spread to kidneys. There may be reactivation or exogenous reinfection. When to think of TB. Think of TB if a patient presents to you with chills, fever, fatigue, difficulty in breathing, anorexia, loss of appetite, night sweats, coughing up blood. Common symptoms of TB include cough for 2 to 3 weeks or more, coughing up blood, chest pains, fever, night sweats, feeling weak and tired, losing weight without trying, decreased or no appetite. If you have TB outside the lungs, you may have other symptoms. Now we will see a few X-rays from the patients who presented with the tuberculosis in medicine department. Primary disease. The X-ray shows the primary disease. The X-ray shows the lobar pneumonia. This X-ray shows the upper lobe cavitary disease. This is an X-ray showing bronchopneumonia. This shows fatal bronchopneumonia. This shows pleural disease and previous pleural disease. Now we will discuss about the miliary tuberculosis. It is due to the uncontrolled hematogenous dissemination. Progressive primary or reactivation. Requires impaired immunity, thus 50% in infants, elderly and HIV positive. Clinical course variable, fulminant to subacute. Non-specific presentation includes failure to thrive, asthenia, night sweats, pyrexia and ARDS. Difficult to diagnose in 20%. There is usually post-mortem hepatomegaly, ascites, deranged liver function. Meningeal disease in 15 to 20%. Other sites include node, skin, meninges, renal tract, pericardial, hepatic and GI bone, reproductive system, eye, microbiological diagnosis, Ziehl-Neelsen acid-fast or auramine stain. Others include Lowenstein-Jensen culture, automated test radiometric culture C14 PCR and other nucleic acid amplification tests. Nucleic acid probes for various mycobacteria. Notification. TB is a notifiable disease and contact tracing is very important. Who was the source? Has the current patient been a source? Outcomes. Not infected patients are usually discharged. Those whose tests have seroconversion but no clinical disease are given chemoprophylaxis. Active disease is always treated. Current treatment guidelines. Respiratory TB. For 2 months, they are given rifampicin, isoniazid, pyrazinamide, and ethambutol followed by 4 months of rifampicin, isoniazid, pyridoxine. Now given as combination drugs. Rifid. Sensitivity patterns are important. Now we will discuss tuberculosis in pregnancy. No increased risk of TB. Women with TB should be advised against becoming pregnant until treatment is completed. Low-dose combined OCP is less effective. RMP enhances metabolism of estrogen. Rifampicin, isoniazid, pyrazinamide, ethambutol, standard dose. Streptomycin causes eighth nerve damage in the fetus and is avoided, and ethionamide is also avoided due to extensive side effects. HIV and TB. Nearly 40 million HIV positive. 70% in sub-Saharan Africa. 12 to 13 million have HIV plus TB. Annual risk of clinical TB if HIV positive is about 10% compared to 10% lifetime risk if HIV negative. Both diseases worsen each other's outcome. Presentations can be similar: weight loss, lymphadenopathy, fever, sweats. TB infection and disease. Can the TB bacteria affect other areas of my body other than the lungs? TB can infect the brain, kidneys, bones, and other areas. TB can also spread through the blood to other organs. This is called miliary TB. Categories of TB active. Persons with active TB need to take their medications as prescribed in order to treat the disease and prevent the spread to others. Categories of TB latent and active. TB disease varies with age and the ability of your body to fight off bacteria. HIV is the strongest risk factor for the progression of latent TB to active TB infection. Only a very small percentage of people infected with the TB bacteria will develop active disease within 2 years. Homeless persons are at increased risk for catching TB. TB cases are rising in the prison population due to the increased number of HIV-infected inmates, crowded environment, and IV drug abusers. The connection between HIV and TB. TB and HIV like to hang out together and they are a bad influence on each other. Dr. James Curran, CDC. Diagnosis, treatment for latent and active TB. Rapid identification and effective treatment for persons with active TB are necessary in order to prevent further spread of TB. Now we will discuss the tools for diagnosing TB infection. MedTerm skin test (PPD), chest X-ray, sputum cultures. It is an extremely important examination question. The MedTerm skin test (PPD). MedTerm tuberculin skin test (PPD) is a skin test for identifying exposure to the TB bacteria, Mycobacterium tuberculosis, latent infection. The MedTerm test is recommended because it provides the most consistent and reliable result. The MedTerm test is read 48 to 72 hours after administration. Induration or not like swelling at the test site is significant and the reaction is measured in millimeter units. Redness at the test site is not measured. MedTerm skin test (PPD). Persons with HIV or diseases affecting the immune system may have no response to the skin test. Now we will discuss about the chest X-ray. A chest X-ray is ordered when a person presents a recent skin test conversion and is suspected of having TB. If a chest X-ray is normal, further diagnostic testing may not be necessary. If the chest X-ray shows signs of disease, further diagnostic testing will be needed to confirm TB disease. Now we will discuss about the sputum cultures and cytology. The sputum specimen is necessary to confirm that the TB bacteria is present in the lung. The sputum specimens should come from deep within the lungs, and should be obtained from the first coughed up sputum of the day, for 3 consecutive days. May be obtained through special respiratory procedures. Treatment for latent TB. Why do you need treatment for latent TB if you do not have the disease? Medication is given to prevent the latent TB from becoming active TB disease. Preventive treatment reduces the risk of getting active TB by more than 90%. Medication, usually isoniazid (INH), should be taken as prescribed by the physician. The duration of treatment is usually 6 to 12 months. INH is an antibiotic that kills the TB bacteria. INH may cause side effects, such as nausea, vomiting, and liver function abnormalities. Therefore, patients will be seen frequently by their doctor until treatment is over. Persons who do not take the medication as prescribed may develop active TB, and treatment may be prolonged. Treatment for active TB. TB is curable if it is diagnosed early and appropriate treatment is started promptly. Active TB can spread to other people if the person is not taking medication to kill the bacteria. When a person with active TB is diagnosed, they should be isolated from other people until the medication begins to kill the bacteria, usually 2 weeks, but sometimes longer. The CDC recommends that infections due to Mycobacterium tuberculosis be treated with several drugs. First-line drugs: INH, rifampin, ethambutol, streptomycin, pyrazinamide. Treatment for active TB: multidrug-resistant TB, MDR. Multidrug-resistant TB is on the rise. MDR-TB means that some TB bacteria have developed resistance, so that traditional antibiotics, like INH, no longer kill the bacteria. This is due to people not taking their medication properly. New strains of the bacteria evolve. Fundamentals of TB. Now we will discuss the infection control practices. Identify persons with active TB early. Initiate effective and appropriate isolation of known or suspected TB cases. Initiate effective anti-TB treatment promptly. Employees should use N95 respirators for any contact with patients suspected of having TB. Screen persons at high risk for TB and provide preventive therapy if infected. Identify and evaluate persons and healthcare workers exposed to infectious TB. Screen healthcare workers for skin test conversions. Conduct surveillance for TB cases among patients and healthcare workers. Initiate airborne precautions when a patient is suspected of having TB. A patient has a rule-out diagnosis of TB. A patient has a positive AFB smear. A patient has a significant skin test reaction. A patient is at high risk for TB, and has pneumonia, a cough or bloody sputum. What are isolation rooms? This is a concept extremely prevalent nowadays also for the corona patients, so as medical students it is very important for us to have a concept of the isolation room. Isolation rooms are necessary to prevent the spread of TB. Isolation rooms should have at least 6 total air exchanges per hour. Isolation rooms must have air that flows from the hallway into the isolation room, negative pressure. Doors to isolation rooms must remain closed at all times to maintain the negative pressure. The number of healthcare workers entering an isolation room should be limited. When isolation rooms are in use, the air flow must be checked daily. Factors contribute to TB outbreaks in healthcare facilities. Lack of compliance with infection control practices to control the transmission of TB. Healthcare facilities which are providing services to increased numbers of people with TB and HIV infection. As a healthcare worker, how can I protect myself from being exposed? Have your skin test performed at least once a year to determine your TB status. Always wear personal protective equipment N95 when taking care of patients with active or suspected TB. Personal protective equipment includes a respirator N95 and may include a gown and gloves. Occupational health and safety protocols for monitoring TB. All applicants are screened for TB. All employees are screened annually for TB, or more frequently if necessary. Employees exposed to patients with active TB will be identified and followed through employee health. Fit testing for N95 respirators. What is fit testing and why must it be done? Fit testing determines whether a healthcare worker can achieve an adequate facial seal with a particular respirator. N95, an appropriately fitted respirator, mask will prevent the transmission of TB to the healthcare worker. Fit testing. What is fit testing and why must it be done? Fit testing must be done prior to the initial use of a respirator mask. Each time a respirator is worn, the healthcare worker should ensure it fits tightly over the nose and mouth. Patient education. Patient education is an essential component to prevent the spread of TB. TB patients should be taught to use tissues to cover coughs and sneezes. Tissues should be disposed appropriately and not left on countertops. Patient education. A surgical mask must be worn by a TB patient whenever they leave the isolation room. Visitors of a TB patient must wear a respirator but are not required to be tested. Thank you for watching. Subscribe MedTerm for more lecture videos and latest updates. Have a nice day.